So in the last video, we talked about the changing economic incentives of the consumers of healthcare. In this video, we're going to talk about the changing economic incentives of the providers of healthcare. Now, in more normal situations, any business would have to be sensitive to the costs that they incur when they purchase a product or try to provide a service, and compare that with the price that they are able to charge and the amount of people or customers that they're going to be able to attract. A grocery store, for example, must constantly think about how much produce to purchase at any given time and weigh that against the price they think they'll be able to charge customers and the number of customers they reasonably would expect to purchase those goods. This is why, for example, grocery stores in places near a bakery tend to have smaller bakeries than a grocery store with no bakeries at all nearby. Prior to 1965, this was also true for hospitals. One hospital in town might have an oncology wing, and the other one not so much. This isn't because the second hospital doesn't think cancer is a big issue. It's because having an oncology wing is expensive and is only worth it if there are enough patients willing and able to pay to actually support it and make it financially viable. But with the increase in guaranteed revenues, which in this case comes from Medicare and Medicaid, compared to private revenues, which would come directly from the patients, this changed. In the years following Medicare and Medicaid, hospitals, and ironically, this was especially true in nonprofit hospitals, expanded their capacities, invested in the latest technology, and duplicated facilities and services offered by nearby hospitals. Now, normally, you would expect this to lower prices because, after all, it increased the number of sellers on healthcare, and competition should force prices downward, right? Well, you're right and you're wrong. You're right in the sense that if we look at supply and demand, this is going to look a lot like an increase in the supply. And as we know from Econ 101, when supply increases, price should go down. But this competition that forces prices downward only works if people are actually sensitive to price, i.e., if people are actually worried about how much something costs and are able to shop around for the best prices. In the case of Medicare and Medicaid, and also the rise of insurance plans, what we effectively did is divide this country into two camps: people who had Medicare, Medicaid, or insurance, and people who did not. For the people who did have these programs, sure, their out of pocket expenses went down. But the total price that society paid went up. In other words, we created a wedge over here. So the total price that society pays is here, but the price that is actually paid out of pocket might be down there. People who do not have access to these programs, Medicare, Medicaid, or insurance, would end up being stuck paying the full societal cost to have their medical care. But that's not all. In addition to changing the incentives of hospitals, Medicare and Medicaid also changed the incentives of some physicians as well. Specifically, physicians who are paid on a fee for service basis, so for example, getting paid for the number of tests you run on you and not necessarily being paid for the results to you or the increases to your health, would have less incentive to care about the cost of healthcare because the more healthcare they provided, the more they got paid. Again, guaranteed in this case by Medicare, Medicaid, and perhaps even insurance. The predictable result is that hospital stays for patients were frequently longer than necessary, and doctors ordered far more tests. The patients didn't care nearly as much as they used to because, after all, these expenses were covered by Medicare, Medicaid, and insurance. And the physicians loved it because it meant that they would get paid more money. Today, the result of all of this, and plenty more, which we'll talk about, is that healthcare costs in the United States have skyrocketed. Similarly, once you're at a hospital, your stay is almost certainly going to be longer today than it was in the past. Though I should be clear that this is in part because, due to the exorbitant costs of healthcare, we are all less likely to go to the hospital for minor problems than people in 1965 were. So we do have a bit of a selection bias going on here. Finally, you are more likely to have more tests done on you today than you would have had done on you in 1965. Now, I am deliberately starting with this example as a means of really shocking people into thinking about this. The point of this class is not to talk about how poorly the government has done, but instead it is to provide some history, context, and economic analysis to the underlying problem that is the fact that healthcare in this country is currently so expensive that it precludes and prevents millions of people from being able to access this vitally important resource. This program, Medicare, Medicaid, and health insurance, are but one aspect of an incredibly complex web that has resulted in what we call today the healthcare crisis. We are going to take plenty of time this semester to try to untangle as many pieces of this web as we can, but this one should just get us kind of rolling a little bit.